You have seen Brian's CV on the flyer and his bio, but I do, just as a matter of respect, as I introduce you, Brian, just read a little from that to put your expertise and experience into context. Brian is Conjoint Professor in the School of Psychiatry at the University of New South Wales, Director of the Academic Department for Old Age Psychiatry at the Prince of Wales Hospital, Deputy Director of the Primary Dementia CRC, part of the World Health Organisation consultation group on the classification of mental and behavioural disorders in older adults, and he's also on the Medical and Scientific Advisory Panel for Alzheimer's Disease International, the global peak body for diseases related to dementia. Dr Draper Brian has published over 200 scientific articles and book chapters on topics that include clinical aspects of dementia care, including younger onset dementia, acute hospitals and dementia in Aboriginal people, carer stress, depression and suicidal behaviour, as well as the book Understanding Alzheimer's and Other Dementias. We are really privileged to have the opportunity to have Brian as part of our 2014 public lecture series, and I'd like to welcome you to the podium. Thank you.
Thank you very much for that nice introduction, and it's a great pleasure to be here in Perth for doing this, because it's part of a national tour that we're doing to try to address this issue about dementia care in acute hospitals. I think I was talking outside just beforehand to some of the people here and pointing out that for a long time there's been a lot of anecdotal evidence that people with dementia don't get a really good deal in hospitals. And it's only really in the last 5 to 10 years, 5 years really in the main, that the level of the extent of the difficulty has become apparent with reasonable quality research. And so that's what's sort of partly driving a nationwide but also an international drive to try to look at what we can do to get system change, because that's basically what's required. I'm going to go through these sets of issues and, first of all, relatively briefly, explain the extent of the problem and look at why people are in hospital, what are the outcomes. But I want to focus mainly, the larger part of the presentation is what can we do about it? Because I think we already know there are problems, and I think it's much more important to focus on what could be done at a system level and an individual level to make change. And I'm hoping that's the main thing that I'm trying to achieve tonight. So I think the biggest challenge is actually identifying people with dementia in hospitals, because this is not being done that well. And I'll illustrate that with data from the 3 studies that were done in different ways. And the studies in their own sense are looking at different ways that people with dementia are identified. So the first study is a prospective study from the UK, in which every person aged 70 years and over that was admitted to hospital got thoroughly assessed by the research team as to whether or not they had dementia. And they found that 42% of people aged 70 years and over in an acute hospital had dementia, but only half of them had been diagnosed before they'd reached the hospital. So in other words, the hospitals, half the people who had dementia in hospital, people didn't know about it outside of the hospital, let alone in the hospital. And there were higher rates in women and in those aged over 90, what we would generally expect. So that was a very high quality study that was looking at individual people and making individual diagnoses. Second study is one from Australia, a retrospective geriatrician case note review, and using reasonably well collected data, using standardised instruments, but nevertheless retrospective and needing geriatricians to look at those results and say, well, this person does, this person doesn't have dementia. So this found that 29% of medical patients, and these were again aged 70 plus, and 15 to 16% of surgical patients had dementia, lower rates. Okay, so the lower quality, slightly lower quality study gets slightly lower rates. Then there's a study that I was involved in, the Hospital Dementia Services Project, which relied upon diagnoses as recorded in medical files and as put in New South Wales, for all the hospitals in New South Wales. So we had all the medical records for a whole year, for the whole of New South Wales. And this was a data linkage study, and I'll talk a bit more about it later. And when we looked at it that way, this is looking at people aged 65 plus, so slightly younger, but you can see the rates come down to 12%. And the difference is, of course, that represents in part the failure to the hospital to actually identify that the persons in the hospital had dementia. So, I mean, it's not that in New South Wales when you have 12% of dementia, and in Brisbane 29%, and in UK 42%, it's got to do with how well it's identified. And that is a simple illustration of the extent of the identification problem. And again, this is looking at our study from the Hospital Dementia Services Project and showing the age-related changes. And the blue bars are the hospital patients, the red bars are the population estimates for New South Wales. You can see even with what we would probably regard as an underestimate of people in dementia in hospital, there are still more people in hospital than you would find in the general community. And in fact, even based on that number, we estimated, because we had data linkage, so we had individual people that we could identify, not their personal identification, but we knew that we had different individuals, that 25% of people with dementia in New South Wales were admitted to hospital in that period. So 1 in 4 people just on that data are going to hospital. So hospitals are a big part of the lives of people with dementia, whether they're there for reasons related to the dementia or not. So, and I suspect the numbers are even higher than that in terms of the proportion. So why are people in hospital? Well, it's not that much to do with dementia. In fact, in our study, it was only about 6%, just over 6% of the people with dementia were there for anything to do with the dementia directly. Most people are in hospital because they're acutely unwell, with urinary infections, with chest infections, having a fall and injuring themselves, fracturing their hip, having a head injury, becoming dehydrated, having a stroke. These are the reasons people are in hospital. And I mean, that doesn't surprise us because that's what hospitals are there for, of course. So that automatically, or should automatically, raise the first issue. People are there, that people with dementia have a comorbidity for these other problems. And so hospital systems in general are not set up to deal with those comorbidities as well as the acute problem. And so that, in an acute hospital setting, becomes a bit of the set part of the dilemma. But it's important to understand that having dementia really increases your risk of going to hospital for all of these acute problems. So in our study, when we looked at the various common health problems that people were there for, people with dementia had 1.64 times higher, so 64% higher risk of being in hospital with a lower respiratory tract infection than people without dementia. People fractured femur, 160% higher. You can see right down there. And the colours in blue with the times higher are a reflection of that this happens mainly in older people with dementia. The bottom two, alcohol disorder and epilepsy, there's a bit more preponderance for younger people with dementia. And in fact, I think it's interesting to see the alcohol disorder there. This is not saying that the alcohol was the cause of the dementia. This is a comorbidity. So one of the things that we're seeing here is that people with dementia who do drink a bit too much, if that happens, that is very highly likely to get them into a hospital, even if it's got nothing to do with the cause of the dementia. And this is something I think is an important issue because it has implications for management, of course. Obviously, head injuries, TIA, stroke, we've talked about that. Constipation, I mean, it's not surprising, but people with dementia are much more likely to be in hospital with constipation as their main reason for being in hospital. So what happens to people with dementia in hospital? Well, they're more likely to have a procedure or a clinical investigation than people without dementia. They're more likely to have an adverse clinical event in hospital. Things like having falls, skin tears, having too many drugs given to them, pressure ulcers, infections that they acquire during the hospitalisation. And of course, these all increase the risk of dying and mortality in people who have an adverse clinical event with dementia is 20 times higher. So if you have dementia, you develop an adverse clinical event in hospital, you've got a 20 times increased risk of dying. And you likely require more nursing care, of course, that's self-evident in a way, and much more likely to become more confused than you were at home. And indeed, when we looked at this in our research, in nursing, one of my colleagues, Cassia Bale, led this aspect of the study. She was interested in what kind of potentially reversible or potentially preventable complications of nursing care, if you like, could be attributed to people in people with dementia. And there's a well-established list of such things which is unrelated to dementia care. And I've got some of the list here: urinary infections, pressure ulcers, sepsis, pneumonia, delirium. And as you can see, with all of these problems, both medical and surgical wards, people with dementia have much higher rates. So we have here, this is, as I say, an internationally recognised list of potentially preventable complications of hospitalisation. People with dementia are not doing very well on any of those parameters. And in fact, people with dementia have double the length of stay, even when you take all the other comorbidities and other confounding factors into account. They have double the risk of dying in hospital than people without dementia. They have a 7 times increased risk of being transferred to a residential aged care facility than people without dementia, and an increased risk of readmission, about 30% higher in the next 3 months. So on virtually all of the main markers that we have for quality care in a big picture sense, people with dementia do worse. One of the questions I've mentioned the double the length of stay, and so it does raise the question, is a shorter length of stay a proxy for good dementia care in hospitals? And there are pros and cons here, because it's not a simple answer. Yes, it could represent earlier diagnosis and therefore getting on top of the problem quicker. Could it represent better quality care with less preventable complications and more efficient hospital and better hospital community interfaces? These are all relatively positive things. But maybe no, maybe some people are prematurely discharged. Maybe it represents higher rates of transfers to another hospital, or maybe it represents higher rates of transfers to a residential aged care facility. So it's not black and white. But on the whole, it's probably in the main is a positive marker. And of course, a longer length of stay, we can identify quite a few different reasons why that might be a good thing. It might be appropriate use of forms of subacute care to allow a person to rehabilitate after a fracture or other injury. It might be that you want to keep the person in hospital for those few extra days so that you can make sure that there are some community support services in place post-discharge to prevent a readmission. So that might be a good thing. And of course, it might be that there might be a circumstance where there's no residential aged care facility, and the choice is sending them home to await the placement or to stay in hospital awaiting the placement. And of course, most people would say, well, in most circumstances, waiting those extra days in hospital would be a better thing. So there are reasons why a longer length of stay in some people might be a better thing. So what can we do to improve outcomes? As I said, I'm going to spend most of my talk looking at possible solutions. I believe that the evidence is pretty strong there's a problem. So we now need to say, well, what can be done to improve this? I think first thing is avoid admitting people with dementia for conditions that can be safely and appropriately treated in situ, whether that's in their own home or in a residential facility. And I stress appropriately and safely. It requires that we need to provide some kind of outreach, either to the home or to the facilities, to do that. So there are various geriatric outreach services, flying squads we call them locally in where I work, to assess acute problems and treat them in situ if possible, with nurses and other allied health to support. Encouraging residential aged care facility residents to have an advanced care plan. That is, to basically prevent an unnecessary transfer of a person in a nursing home to a hospital in the middle of the night when the person didn't really need to be there and could have been managed in the facility, so long as there was some evidence of what plan was in place. So, and then, of course, there's aged care staff in emergency and hospital and home services for those people who are discharged earlier from hospital. So, in other words, to shorten the length of stay and so forth, and prevent readmissions, the idea of that. So just going through a couple of these things. The advanced care planning. This is a process of planning for a person's future health and personal care, and it's best undertaken with involvement with the GP, the carer. While the person is competent, it helps, but that's often not the case. But it can include whether or not a person should be resuscitated, taken to hospital, treated with antibiotics, etc., depending on the stage of the person's illness. The intent is to allow the person to decide how and where they want to be treated in the end of life. And there's evidence that this has been done in a number of studies now in nursing homes, and that can reduce the rate of transfers of people to nursing homes, from nursing homes to hospitals, and often they're sent back within a few days. And it just reduces this unnecessary turnaround of people who, because the nursing home didn't have any guidance as to what should happen, they couldn't get a GP in to help the person in the middle of the night. They do it send the person to hospital. So there's a lot of this type of thing that could be done, and it's certainly something that I would strongly recommend. Outreach services to provide acute care. I talked about this, the flying. So this is two types of specialist multidisciplinary geriatric services. And usually it's usually geriatric services. The rapid response to acute medical conditions, especially in residential care, and we have a number of these now around Sydney. I wouldn't be surprised if there are a number of these around Perth as well. But these there's not enough of them. There are still many hospitals that don't have these sort of services. And the idea, of course, is that you respond to the emergency in the facility, and you have often agreed guidelines as to what sort of emergencies that this is appropriate for, and a very quick acute medical response allows then early diagnosis, and for the sort of people who can be managed safely in situ in the home, with perhaps some support from nurses, allied health coming in for a number of days, maybe to help with intravenous therapy or whatever it might be, then a lot of people can be treated at home or in the residential facility without having to go into the hospital. And of course we know that people who are treated in these sort of ways are much less likely to get confused, much less likely to get delirious. So it's not just to try to save money or to avoid hospital, it's in fact to give a better outcome. And in fact, where these have been evaluated, carers are usually happier, patients have less adverse effects. So in a sense, it's a win-win situation. And of course, the follow-up or continuing care of those discharged from hospital and in essence, to make sure that that recuperation period is done effectively, and you can capture any complications that might be happening that might be able to be nipped in the bud, and so the person doesn't get sent back to hospital again. And these all can be done. Obviously, it involves the GPs. I can't stress how important the front end of a hospital is, the emergency department, and how, when and why a person is admitted to hospital plays a key role in determining what the outcome of care is. And so, for example, people with dementia in our study, admission on a weekend was associated with a shorter length of stay. And you just ask the question, is this because on the weekend people, they don't have services, maybe they're concerned that sending the person home might not be easily achieved, or is it because people aren't sure and people are admitted to just to clarify the problem? Because it's the opposite for people without dementia. People without dementia who are admitted on a weekend have much longer length of stay than people who are admitted midweek. So there's a different thing happening with people with and without dementia. And having specialist aged care staff in the emergency department tends to reduce length of stay. And it probably does that because correct initial diagnosis and assessments are put into place as early as possible. In New South Wales, we have what we call aged care service and emergency staff, ASIT. And when we did our research, so the research was based was done partly with site visits occurring in 2010. These had already been, they'd already started and they were sort of spread across the state, but there were more being put into the system. And these were based in emergency department. They focused on the older admissions and assessed function, cognition, a whole range of general aged care things. And they liaised with all the rest of the emergency staff and community staff, etc. And they provided advice about discharge, about which people should be. And basically, what we observed, because we did, as I say, site visits to a lot of hospitals, was that they were the key people to sort of say, well, look, this person, you really shouldn't admit. He doesn't, it would not a good. There's no real reason to admit this. We can look after this person very safely at home, so long as you can allow me to coordinate this, that, and the other. Or the opposite. This person really needs admission, and you shouldn't be thinking about sending them home because this is a really dangerous, whatever it might be. But these people were highly valued in the hospitals. We spoke to a lot of emergency care staff, and a lot of them sort of said to us, before this was set up, we were a little sceptical as to what they could contribute to the system. But now they were so highly valued, they were seen as being key, most integral part of the emergency system. It was interesting how just by being there, they demonstrated their worth. And so highly important. What can be done to improve outcomes? Well, developing protocols to screen older people's cognitive function upon admission or within the 24 hours of admission. I mean, there are numerous studies that demonstrate that it's not done well. And many studies have looked at this, and in Australia and around the world. And the main concern, of course, here is to identify delirium. The key issue here, really, in the first place, is this person got an acute medical condition that caused him to be delirious? And that's the key factor at the front end of the hospital, because that's what needs to be treated urgently. But of course, finding out their cognitive state, if it's not delirium, then it gives you a hint that it's probably some form of dementia, or a combination, which is, of course, most often the case. And untreated delirium's got a terrible prognosis. It's got a poor prognosis even when you treat the underlying cause, but untreated prognosis is abysmal. And between 50 to 60% of hospitals that we looked at across the state of New South Wales, so we surveyed all the public hospitals, said they had protocols, but it's unclear how often they were being used. And indeed, having protocols or policies has been shown in the UK not to closely relate to what actually happens. So you can see here, this is National Audit of Dementia Care in General Hospitals done in the UK in 2011. And the proportion of the hospitals that had policies and the proportion that was shown to actually translate into something happening in the case notes was really quite a big gap. And I've got no reason to expect that in Australia that would be any different. So we have been a number of projects in Australia attempting to improve this, and mostly focusing on delirium, of course. So there's the National Clinical Practice Guidelines for Management of Delirium in Older People that came out in 2006, and then there was a Delirium Care Pathways in 2011. And in New South Wales, our Clinical Excellence Commission developed some quality self-assessment tools to see what hospitals were doing. So people around Australia, and I'm sure other states have been doing different things too, have been looking at this, but it's still not really moved to the next step of actually leading to change. One of the things that we hope will make a change is the National Safety and Quality Health Service Standards. There are 10 standards that hospitals have to abide by, and they're listed there. 10 national standards, and governance, partnership with consumers, infections, medications, and you can read the rest of it there. Not one of them relates to cognitive disorders. And this is a problem, because these standards are what hospital managers have to get their service quality assessed by when they have accreditation. These are the basic standards that they have to meet. So if you don't have a basic standard in a hospital that's got anything to do with cognition, whether it's due to delirium or dementia or any other cause, then the hospital managers aren't that interested. So the ACS, the Australian Commission on Safety and Quality in Healthcare, are actually working on this currently. So, in fact, at one stage, we were hoping that they would be able to join us in this tour, but it was just the timing wasn't quite right. So, but anyway, they're working on it. So they have been doing a big consultation around the country and finding out what people's views are on the topic. And they've developed a handbook which is currently in draft form. It's a wonderful bit of work. When it's finalised, it's going to be very useful for staff at the coalface and for carers and for people with dementia. And one of their key recommendations will be that in 2015, when the national standards are reviewed, that at that point there needs to be a consideration for an additional standard on delirium and a basic strengthening of standards to fill in quality and safety gaps that are relevant to dementia. Unless that kind of change happens, it's not going to have that much influence on the people at the top in the hospital system to see that they have to do something. There are other approaches that are currently in the process of happening. So the Melbourne Epicentre, the University of Melbourne, and the Royal Melbourne Hospital got funding through the Victorian Department of Health just earlier this year to develop dementia care pathways in acute hospitals. And the idea is that they want to obviously do it for their local need, but they want it to be an Australia-wide application. And so basically these are structured multidisciplinary care plans used by health services to detail essential steps in the care of patients with a specific clinical problem. That's what a care pathway is. And it's aiming to link evidence in practice with and optimise clinical outcomes. And in other conditions, it's been shown to improve outcomes if people adhere to these sort of pathways. So it's a 3-year project, and it's just in the early stage. I'm one of the people involved with the advisory group for the project. That's why I know a little bit about it. But this is just a draft to get a sense of what. So, I mean, don't try to read that, but you get the sense of a flow chart that would be there for key staff in emergency and in wards for clinical issues related to people with dementia. It just tells you, well, if this is the situation, consider this, that, and the other type of thing. Very simple, very practical, and it's just to help people make sure that they know what they're doing. Because the fact is, a lot of people don't know what they're doing. And I'll talk a bit more about that shortly. And of course, one of the other issues in acute care is that there are too many problems and there are too many tools. It's already well, we're interested in dementia and cognition, but, you know, cardiologists are interested in how the heart goes, the respiratory specialists are interested in how their people are breathing, the diabetic specialists are pretty clearly interested in their blood sugars, and the kidney people, you know, and it goes on. Everybody has a screening tool for something, you know, and so it gets to the point where you've got so many tools, and if you're trying to involve staff who would have to do a lot of different things, it becomes very confusing. It's very hard to get an uptake of doing these things. And there are many validated tools for measuring cognition, short ones, and I'm not proposing one or another here. I've just listed a couple without putting any support for any of them. But the point is, there are plenty of tools out there. We don't need, in one sense of the word, we don't need new tools, but in another sense of the word, we do. And one of the things that one consideration that Len Gray from Queensland, Professor of Geriatric Medicine there, he's been working on this inter-RI suite of tools. And essentially it's a self-contained group of tools that cover all of these things, cover all aspects of nutrition, cognition, mood, etc. So one possible solution, and I don't know if it's the best or not, is maybe we need to think about trying to simplify the way that we screen in these situations to allow people to use a group of tools that can actually cover a lot of things simultaneously, rather than having to think of using different tools in different situations. Staff training is really important, and it requires leadership. It needs to address hospital culture, involve all staff, and be relevant across urban and rural settings. Whatever we do has to be... There's no point developing a program that works really well in your major teaching hospital in Perth, but doesn't work really well in your local rural hospital 200 kilometres away. You've got to have a program that kind of works almost across the board, or variations of the program. And there's a couple of ways that this has been done across Australia, and I'll talk about a couple of them: the Ballarat Dementia Care in Hospitals program and the CHOPS program in New South Wales. But basically, these programs have a lot of things in common, and encouraging multidisciplinary and interdisciplinary teamwork is often part of that, and involvement of carers. And now I'll also talk about the Top 5 program from a local health district in Central Coast Local Health District, just to give you a sense. Now, hospital culture is something that's so critical here. In our site visits, as I said, we visited 20 hospitals. 10% of the hospitals in New South Wales we visited, spent a day and a half at these hospitals and just watched, observed, interviewed people, and so forth. And, you could see some hospitals just had the wrong culture. They would use terms like the demented ones, those that act up. There was these demeaning ways of describing people with dementia. And their approaches were that people with dementia were a problem. They were the problem child. Really, why do we have to bother about them type of attitude. Clearly, this hospital cultures, when they're like that, are quite toxic and are hugely important to turn around. The Ballarat Dementia Care and Hospitals program is a great example of how leadership at one level, or multiple levels, can lead to system change. So this is a program developed by Mark Yates, geriatrician in Ballarat, and its colleagues Meredith Theobald and Michelle Morvell. I think they're both nurses, but I'm not 100% sure. So it's an all-of-hospital education program, and this is key, all of hospital, including the cleaners, including the reception staff. Everybody has to be part of this program to improve the awareness and communication with people with dementia. So that's their focus. And it's linked to a visual cognitive impairment identifier. I'll show you that later. And they screen everybody for cognitive impairment, and they identify the nominated carers, and they engage with that person during the stay and in discharge planning. And they've evaluated this at Ballarat and in 22 other hospitals. They've rolled it out across Victoria. And basically, the outcomes are quite positive in terms of staff and carer satisfaction. And so this is the visual cognitive impairment. So basically, when they screen for people for cognitive impairment, those that are screened positive have one of these little signs above their bed. I mean, obviously, the carers are told about the meaning of this, but this indicates to the staff that the person has a cognitive disorder, whatever the cause might be. Okay. Now, there are some people who say, oh, I'm not sure about that. So there are pros and cons of whether we do that. But this seems to work very well in this system, and it seems to be quite an effective way that they can do it. But I think the key is the training of staff, the whole of hospital approach. It made me, when I first heard Mark talk about this, it made me reflect about my hospital, my ward. And I realised that one of the most effective staff members that we have on our ward was the cleaner. And she's wonderful. She takes people under her wing all the time. She helps people, gets them engaged in doing meaningful activity. Person will help them clean up something, but she does it naturally. And I asked her last week, what training have we ever given you, for what you do? Nothing. We've never done a thing. And I've realised, well, this is a real gap. We'll have to. Fact is that she's a natural. She just knows what to do, does it, because that she can see it's a thing to do. And she feels she loves her job, and she loves that interaction, and everybody values her. The staff value her, and the patients value her, and the families value her. But, it made me realise that we've got a way to go in our own place for doing that. I know we've certainly got educated our front-end staff, our receptionists, but we hadn't focused on that at all. The other program is in New South Wales, the Confused Hospital Older Persons program. I had a little bit of involvement with this one. This is led by the New South Wales Agency for Clinical Innovation. And again, it's very similar to the Ballarat program. It's aimed to improve care and reduce harm for confused, hospitalised older adults through training, again, use of cognitive screens, again, and education support, and again, move towards the concept of a brain-friendly hospital, hospitals that are aware that we have to do something to look after people who've got some brain impairment. And they piloted at 5 hospitals, and outcomes have showed already increased education, cognitive screenings increased, delirium risk assessments have improved, confidence is improved in assessing and managing delirium. These are 5 hospitals, both rural, urban settings. So again, we can see that these sort of programs can work. And of course, the 5 hospitals were chosen because they had leadership that wanted to change. You know, the leaders of these hospitals, key people in these hospitals, recognise we have a problem, we want to do something about it, we want to engage with this program. Obviously, the challenge is, well, what about those hospitals that don't recognise they have a problem and don't have the leadership? Well, that's really important. That's where we've got to sort of work out ways to get the leadership in some of these hospitals understanding that they need to do something about it. And so these are the basic principles of the CHOPS program. Cognitive screening within 24 hours, delirium risk identification and prevention strategies, assessment of older people with confusion, management of them. So they go through so it's not just, you know, in these situations, it's all well and good to say, oh, this person has confusion perhaps due to delirium. You've got to do something about it. And so this is the program emphasises the actions that need to happen. And talking about communication, again, the support person is very important. So you see there's some commonalities of these programs that work, that have got evidence that they work. You know, some certain key features, and they're not complicated features. You know, we're not talking about changing the world in the sense of doing totally new things. We're just talking about doing things that we know anyway, and they're shown to work. Education is very important. One of the things that we noticed in our site visits to hospitals, particularly though, well, in all hospitals really, but I was particularly interested in hospitals that didn't have aged care services. And we noticed, you know, we visited, I'd say only about a third of the hospitals we visited in New South Wales had big multidisciplinary aged care services on site. I mean, most of them had people that visited, but actually on site only about a third did. Some of the hospitals were fairly small. But I was interested in how did hospitals operate that didn't have aged care services that seemed to be doing it well? And one of the key things was this multidisciplinary, interdisciplinary teamwork. And we noticed how that this was a very key part of how they were working. They had allied health and nursing staff interfacing with GPs or visiting specialists in a very proactive, positive way, and often involving the community staff who come into some of these. And you could, you know, we just sit there and observe their case discussions, and they were very broadly, organised discussions. So it was quite a joy and a privilege to watch some of these. And these were necessarily without aged care geriatric. These are hospitals that kind of worked out this is a style of how we should do things, and it clearly was working. So these are various ways, and of course these kind of approaches of having these interfaces and having this kind it's a key part, I think, of what can you do if you've got limited resources, because every hospital can do this if it sets its mind to it. Even if they have limited resources, they can work in this kind of way. The Top 5 program in Central Coast is quite an interesting one, one that impresses. So this takes the view that the most important person that we can communicate with about a person with dementia is the carer. And the carer is often left out of the loop. Often the carer, person goes to hospital sort of asks certain questions, but really they miss the point that this person knows the person with dementia best. Nobody else knows them as well as the carer. That's, of course, obviously if they know that the person has dementia, so that's a separate issue when they don't know that. But even in the situation where the dementia is newly diagnosed, they still know a lot of things about how to interact. So in this program, the staff member explains the program to the carer at the time of admission and gives them that brochure that's on the side there, and invites the carer to share care tips and strategies that work for them. And these are recorded on a top 5 form, and it's usually up to 5 tips, and which are accessible to all staff. So it might say something along the line, Jim really doesn't like having a bath in the morning. He's got to have a shower at night. Jim, he's very finicky with his food. If you cut up his meat, he might eat it. If you just put it in front of him, he'll very simple, practical tips. And these evaluations are very positive, and they seem to work because it's a way of sharing information through all staff who are looking after that person. And of course the carers feel that they're being listened to, and the outcomes are there's reports that the patients are more settled because people are doing the things that they're used to and comfortable with. Specialist aged care staff and wards. The question is asked, well, are hospital outcomes for people with dementia related to the types of resources that are available? For example, multidisciplinary specialist aged care staff with geriatricians available on site, specialist aged care wards, specialist input to other parts of the hospital, including ED. This is one of the key questions that we were asking in our research. The Hospital Dementia Service Project was a very complex project, and we took data from 6 sources, all of the New South Wales public hospital admissions in a 12-month period, over 250,000 patients and over 20,000 identified with dementia. We surveyed all of the public hospitals. We got survey response back by 83%, which represented about 95% of all the patients that were in the hospital in that period. We got qualitative data. I've mentioned we did that. We also linked all of those data with residential aged care data and ACAT assessment data, and also the regional provision of communities of services. So it's a very complicated data set. In fact, it crashed the AIHW where we did the data, crashed the computer system one night, and it was so much data there. So one of the key questions is we use what we call multi-level modelling. So we put all of this information together, taking everything into account, and using length of stay, using shorter length of stay as a proxy for good care, and reduced rate of transfer to residential aged care as a proxy for good care. And yes, geriatric services in big urban hospitals where they've got the full kit caboodle do better. Even when you take everything else into account, the nature of the patient, the comorbidities, you throw it in, the socioeconomic status, everything else like that. I mean, the variables, number of variables in the analyses are ginormous. I haven't a clue how they do it, but I just get results and interpret them. But these results are consistent with, when there have been randomised controlled trials out of geriatric services and seen what their outcomes are. So like a trial in one hospital with, a few hundred patients allocated to one type of approach and another. Those studies have shown that patients who are being looked after in a geriatric ward, not an outreach unit, that have better outcomes in terms of cognition and in terms of length of stay and in terms of mortality than people who are not. We know that, the randomised control. This shows, yes, in a practical, in the real world, that's what is shown as well. So in the real world, the randomised control trials show that. So there is a resource issue here. And so what does a comprehensive hospital-based geriatric service look like? Well, these are the things that were part of what did well. They had geriatricians on site each day, not just VMOs visiting from time to time, but they had geriatricians there. They were basically employed at the hospital. Multidisciplinary teams, nursing, allied health, specialist aged care wards for acute and or subacute care, assessment clinics for the outpatients, and emergency departments having specialist aged care staff in the departments, in the ED. That's what it looked like. These are the types of things that did well. And of course, this is the availability of that sort of service in New South Wales. And big red bar on the right is the big cities, the Sydney, Newcastle, NSW of New South Wales, Newcastle, Sydney, Wollongong. As you can see, nearly all of the services are located in NSW. If you go just a little bit west of there, there are a few services, but not many. Once you get out in regional, rural New South Wales, there are none. So there is an issue here of resources related to urban hospitals. Only 21% of New South Wales hospitals had these sort of services. So you see it's not that common. And there were types of hospitals that had a longer length of stay that might represent, I'm not saying they do, but might represent lower quality dementia care. And there were several components that we noticed, that some commonalities about these hospitals. They lacked having specialist aged care staff in emergency departments. They were small to medium sized. They were often in a regional location, so they were not quite in their cities, but they weren't quite out there either. And if they had geriatricians, if they were present, they just tended to visit on a VMO basis, maybe popped in once a week or something like that. They had very high levels of transfers to other hospitals and very few short admissions. And longer length of stay was not found in people without dementia. So basically, they were struggling with people with dementia, is one point I'm making. And that's the general characteristic of it. So in other words, there are types of situations where things aren't going so well. So resources, yes, we could probably say there's an issue of resources. If we can improve resources in terms of specialty care, perhaps we can do better. Hospital design. We found the hospital design of a lot of the hospitals we visited, and certainly in my experience of the other hospitals I've worked at, pretty awful. Only 14% of hospitals had beds that were designed or put aside in a secure sort of way for confused, older, agitated, delirious people, behavioural change. 50% of acute geriatric wards had such beds. So even the acute geriatric wards, there are 50% of geriatric wards in New South Wales that didn't have specialist beds which were secure to reduce risk of harm to the person or other people for the person who was very agitated and distressed. There are very few purpose-built designed aged care wards. In fact, I haven't checked in the last couple of years, but a few years ago I looked at the world literature. As far as I'm aware, there's only one hospital in the whole of the world that's been built, purpose-built for older people. One acute hospital in the whole world is in Canada, on Vancouver Island. Now, there might have been a second one since then, I don't know, but the point is that whatever's there has been adapted. But that one hospital, they decided at the outset, we're building for an older population, let's build into the design of this acute hospital all the things that we know are likely to improve quality of care in terms of design. Of course, the organisational focus on hospitals tends to be cure-oriented treatment, and that means the needs of people are not necessarily addressed in the design. And we did find some good examples of good quality design in parts of hospitals, and I've got a few photos of some of the sort of things that were fairly reasonable. There was one hospital that we visited where they had a lovely unit, and they were full of, all the people in the unit were either having had dementia or were recovering from a delirium and quite confused. But it was like a good residential aged care facility. You go in and you don't realise that any of the people there are confused, because that's the nature of the effects of the environment and the staff training to help people within that environment. And yet you go to other hospitals and you can see that the environments are disastrous, with cluttered arrangements, emergency departments where they've got the older person with dementia sort of next to the person having their heart attack. You can imagine the disastrous situations that can happen for all concerned. And so we saw some good local solutions to problems that were of design, where we saw the staff just working out, well, look, if we can do something, we can actually do something relatively cheaply. So putting people together in a room, painting exit doors with an ocean with cliffs which deterred many wanderers. Lots of sort of fairly simple sort of things in often a hospital or very ordinary hospital design. So I'm not saying all of those are perfect, but these were solutions in hospitals with very little resource. They often didn't have, they had very poorly designed wards and they had very limited personal resources. But they were trying. That was the key. And of course, improving discharge planning and post-hospital care, I've already alluded to that a bit earlier. That interface between hospital and community is really important, and certainly from my own experience in our wards, we spend a lot of time trying to work through who we're interfacing within the community to ensure that that transfer of care works as smoothly as possible. And we observe that in a lot of hospitals that seem to be doing it well. But there are other situations where the GP might get a phone call from the hospital doctor, a week or so, or get a written discharge something a week or two later. That's the first the GP might know that the person never actually been in hospital. You get sort of the extremes, and having these kind of coordinated services where there are linkages between medical staff, allied health and nursing staff in all the settings, it's really important for good quality care. And so we observed it happening, and it can be done. So that brings me to the conclusion that people with dementia are prevalent in acute hospital. I mean, there's a lot of people with dementia in our hospitals, and they do have undoubtedly poor outcomes. So it's really essential we grasp this information, that it's not just an anecdotal report from the upset carer. It's actually a real finding. It's actually a real problem. We've got to change the way acute hospitals operate. If we don't, the problems are going to continue. But a lot of the changes that we can do now. There's nothing that for a lot of the things I talked about that needs that much extra resource. It needs a lot of training, it needs a lot of attitude change, and it needs a commitment. But a lot of things can be done now. And obviously, more resources in some situations are important too. But I think when we can see that we can make change by just changing our work practices and the way we interact with people, I think that's key for what we need to do.
Hi, my name is Jenny Beautis, and I've got a husband who's got very close dementia. What you didn't mention tonight is where mental health fits in with the hospital, because in my instance, mental health intervened and insisted on my husband having antidepressant drugs, which then killed his walking and his eating.
You mean as a mental health problem, as a separate to dementia, you mean?
No, he went into hospital with a TIA, and then he stayed for 3 months because I couldn't care for him. And in that 3 months period, mental health intervened, and they insisted on him having double doses, which took away his walking and his eating, without consultation with me.
Yeah. I mean, we looked at the impact. I mean, we looked at the impact of mental health services in the broader sense of the word, across the system, and certainly there's an important role. I mean, that's what I do. I provide mental health services to the geriatric wards at the hospital I work at. I guess the important thing to understand is that in the big picture, the geriatric services, the broader geriatric medical services, actually are what cover most of what goes on, and the broader general physicians and surgeons. Mental health actually sees a very small proportion of the people there. It's important to have those services, and I didn't show the data today, but very few hospitals actually have access to such services. But in the big, a big level picture, it's more the aged care service, because that's why people are there. They're being there treated for medical problems. Only 6% of those admissions are for mental health related problems. So I guess that's why I didn't talk about it too much. Not that I don't think that it's necessary, but in the bigger picture, it's how we deal with the complications of acute medical problems with people with dementia.
No, you don't answer my question. I'm saying require the antipsychotic drugs because he was not violent, nor did you wonder.
Oh, I see.
Saying
You're talking about that, yeah.
used it as a method to restrain him in his room, treat him very shabbily, leaving him just in and out. I've got pictures and everything, and that's what I'm saying. Hospital care was very poor. The other thing is too, my husband got Lewy body's dementia when he had a TERT procedure. Within 8 hours, he got a massive urinary tract infection, together with the wrong medication, killed his brain. So he was gone within 24 hours, right? The hospital sent him home. This is a big hospital in Perth. Sent him home with no care. For 2 years, I struggled to get some sort of care or advice, and everybody thought it was I who was banned. Thank God for dementia, Alzheimer's in York, who helped me through. Otherwise, I'd go silly. Yeah. I'm just saying, hospitals have got a lot to answer.
Yeah, I mean, on the issue of the antipsychotic drugs, I agree. It's a huge issue. In our local hospital, person who runs the CHOPS program, Professor Jackie Close, she's also responsible in our hospital for oversight of falls reduction strategies across the hospital. And partly through interactions, I mean, I work with Jackie quite a bit in different areas, but we identified that the prescription of antipsychotic drugs was a huge issue. And these were mainly being prescribed not by geriatricians, not by psychiatrists. These were prescribed by a whole range of sundry doctors across the hospital. So a very pointed education program was put into place about 5 years ago to reduce the prescription of these drugs, and it worked. But not only did it work in the sense of the drugs having a much lower prescription rate, but the falls reduced. And so it was a clear relationship between the reduction of falls in the hospital and the lower prescription of these drugs. Of course, these drugs are mainly being prescribed for delirium rather than dementia. But perhaps some of those people had dementia too. But it was just an overprescription. So we did a lot of education. I was part of that, and pointing out to people that prescribing these drugs for delirium was not a good idea. I was also involved in another project in which I was working with palliative medicine and oncology, and they wanted to do some research into how they treated people with delirium at the end of life, and the use of these drugs. What became very clear was that doctors in oncology and palliative care were under the belief that you prescribe one of those sort of drugs to treat delirium, that it was like, you get an infection, put them on an antibiotic. You get delirium, you put them on an antipsychotic, which was quite different to the views of geriatricians and old age psychiatrists. We surveyed a lot of people in this project, and nurses, and it was these quite divergent understandings in healthcare about how you treat confusion in hospital. It's really a very big part of the problem. It's not, so we've got to get information out to people like the surgeons, to the general physicians and so forth, and that's it's an important but huge task.
What is in Sydney?
Response time for
the flying squad that goes out to...
I couldn't tell you because I'm not involved in it directly, but I think it's within, they try to do the same day if they can, certainly 24 hours, but I couldn't say precisely. But these have become ubiquitous around our patch, and all the major local hospitals now have them, and it's made a huge difference,
And also, is there any interest being shown by private hospitals into this type of...
So could you...
any interest from private hospitals into this type of response to climate?
Not that I'm aware of, but that doesn't mean that there isn't. I mean, there's... our research focused on public hospitals, so we didn't collect any data from private hospitals, but I know Mark Yates in his Victorian program was telling me the other week that there are private hospitals who are interested and have been, I think maybe one or two of those hospitals I mentioned that had been rolled out in Victoria might have been private hospitals, and so it's not like they're disinterested, but I'm not too aware of how they're doing. But there's no reason why none of these things can't be done in private hospitals. It's all possible.
Is dementia hereditary? My mum's diagnosed with it. And also, now I forgot what I was going to say, probably through nervousness, I hope, and not through dementia. Is there a link between if a person suffers with depression and then do they progress onto dementia?
Taking the first question first, yes, there are genetic links, but in most people those links are a bit like, I've got heart disease in the family, I've got a higher risk of having heart disease. There are a few very clearly understood genetic disorders where it goes down through the family, and this mainly happens in younger people. But these are a very small proportion of all the people who have dementia. But a lot of people with dementia have a genetic contribution, but there's a lot of other factors involved. The second question about depression, there are two links there. The first one is in older people, having depression in late life may come anything up to 5 or more years before dementia is diagnosed. And in that kind of situation, we tend to think that perhaps what's happening is that the brain is already having some trouble, and depression is an early expression of that process. It's part of the prodrome. You may or may not have memory problems at the time of the depression. It may or may not clear up entirely. So some people have an episode of depression, get better, seem to be well for a few years, and then the memory problems happen. Other people become depressed, never seem to get really better, and their memory starts to decline. So it's not one set pattern. There's other research that's looked at people who develop depression in early life and whether they have a higher risk of dementia in later life. And yes, there is a probably doubling of the risk. And that seems to be mainly vascular types of dementia rather than Alzheimer's type of dementia. And we think that the likely link is lifestyle issues. So people who tend to get depression have a higher risk of smoking, higher risk of drinking too much grog, not looking after their general lifestyle as well as people who don't have depression. I mean, that seems to be the kind of link.